My name is Joe Brandon, and I'm here with all of my wonderful coworkers here at the Shepherd Center.
Hi, Joe.
And I'm doing my I'm doing my presentation for fourth semester. And I did mine on electric medication administration, reconciliation systems, and how they save lives in the hospital setting. I enticed my coworkers with pizza, so excuse me if you see a lot of people moving around and whatnot. But I'm going to go ahead and get started. Everybody has had, they have the packet as well. They may or may not flip through it with me as I go, but I have provided them. Okay, so the first slide is, medication errors are a major problem due to the high costs of running a facility. Many hospitals are running on shorter staff, so that leads to people feeling rushed and more errors occurring. And it occurs a lot that the wrong patient gets the wrong medication when a nurse is in a hurry. And also 26 to 38% of medication errors occur during the time of medication administration. And in here I've also included my citations. So the main objective here is to show that the use of electronic medication administration reconciliations save lives, but also save the hospital a lot of money in the long run. And though it may seem like a big task to start a new system, it will pay dividends, like I said, in the future. And I also want to make this a fun process, learning a fun process, hence the pizza. Because PowerPoints, we all know, aren't too fun and interesting sometimes, so try to make it as fun as possible. And the reason I chose this was because when I was a new nurse, I had a nurse at another facility, and the doctor had ordered an elderly patient 1 milligram of Ativan, and she said that she gave the patient a nurse's dose, which was 2 milligrams, and the patient went into respiratory failure and died. So I don't. Again, the physician said that it couldn't have been because of the Ativan, but I know what the nurse told me, So that always kind of stuck into my head, And one good thing about EMARS is that it shows alerts. It'll tell you give 1.5 milligrams of this or give a half dose of this. Oftentimes it makes us verify things with another nurse, before we are able to administer it. And we're supposed to go watch the nurse dispense of that portion not given, so. The root of the problem is not paying attention, being in a hurry, rushing through MedPass, feeling rushed. You may be going to a patient's room, then this patient calls you and they really need to go to the restroom. You're afraid of them falling, so you rush to that patient's room. Well, you just dropped the pill on the ground, or you just took the wrong medication into the wrong room, Another issue is, come in. Hi.
Hey.
Enjoy some pizza, okay? Paper Mars are also oftentimes, when we use Paper Mars, they're not taken when Dr. D sees an order. Let's say Dr. D sees an order at noon when we're doing MedPass, or at 7 p.m. right when the night shift starts. We don't go back on the Paper Mars and put DC, So a lot of times we miss, that's missed, and it's nobody's fault. It's just a lack of communication, a break in the chain. Again, understaffed units and lack of communication sometimes between RNs and MDs. Oftentimes with the EMAR system, the MD actually puts in the order, so there is no, I didn't know the dose or this or that, not to put it in. So that's the dose that we wanted to have. Also, pharmacy can be alerted to if the dose was unusual that the doctor put in. The pharmacy sees the EMARs too, so they can call or make us call. The changes that need to be made. And this is an important quote. It says, when data, information, and knowledge are interwoven into a computerized system, an electronic wisdom may be formed, which in turn can lead to better patient outcomes. So oftentimes with the EMAR system, the patient's armband is scanned into the computer. It will only allow the med to be administered if that patient if the armband scans to that patient's EMAR. And that's the only way that's going to actually allow us to give it. So my PICO question was, do hospitals that use an electronic medication reconciliation system encounter less medication errors than those which do not? Hey, Susan.
Hey, honey.
Come on in and get some.
Okay.
You got a salad, huh? He's going to help you.
Yeah, we'll go with that.
Okay. Evidence that EMRs work.
She's filming.
She's filming him.
No,
It's just in the way. It's right here.
So there is evidence that EMR systems work. When a computerized system is made, the system combines the patient's medication with the prescribed medication, and the risk of human error is greatly reduced. We oftentimes get medication alerts, such as if the patient is on Coumadin, it'll ask us what the INR is before we give the Coumadin. If the patient's getting metoprolol, lisinopril, it may ask what the blood pressure is, what's the heart rate. This will help lower the chance of giving a medication that shouldn't be given. We give Metadrin a lot at the Shepherd Center. So if a systolic blood pressure is too high, or if a diastolic is too high, then it may ask us to hold the Metadrin, and this would be implemented into the computerized system. And again, we already went over like the half doses, the narcotics, the waste aspect of it. Wasting narcotic or a benzo with another nurse. One study found that the cost of medication waste went from $300 to $30 a month.
Wow.
So
That's significant.
that's a lot of money, right? In the long run. Also, the same hospital found that in the medication administration, the medication administration process was streamlined in a fashion that saved them 40% of medication administration process, so 40% off the time. And I know in Nurse Senate yesterday we talked about different ways to reduce medication pass time. I know a lot of us said that we thought that more staff may do it, but there also may be a better way to, to get the system rolling. The first step to any problem is you got to acknowledge that there is a problem. This is going to take clear evidence of what we had isn't working as well as it could work. And again, with any change, as we've seen, you're going to meet resistance. People are going to leave the job. You're going to get fresh blood. The people who really want to learn will stay. Especially sometimes people who've been in hospitals for a long time may opt to lose just because the change factor. As humans are resistant to change. It will be really important to educate staff thoroughly, because if you understand why you need to change, then you're more likely to accept the change. If you understand what the change entails, you're more likely to be embracing of the change. Okay, so the system, prescribing, transcribing, and dispensing should all be computerized in order to have an effective EMR process. It should be as user-friendly as possible, as high speed, as easy flowing. The pharmacy, the medication system, the nurse, the physician should all have access, and like I said, it should be streamlined as much as possible. And it would be good to choose an IT team that would be willing to stay with the program for the initial year and follow up thereafter. Also have the hospital IT team thoroughly informed about the system and knowledgeable on the workings of the system. I thought you had a salad, Susie. That's not a salad. You really tricked me. You really got me on that one, Susan. Who should be involved? Choosing the right system can prove to be a difficult task, and it will be important to have the right team set up. This should include doctors, nurses, upper management, leadership. As part of the process, it's going to be really important to have charge nurses educated in the system, because who do you always go to for any hiccup? First, if you go to charge nurse, that's Tiffany, Darren, Netta. Misty. That's pretty much it. That's pretty. Those are the people we go to. So we want for them to know the inner workings of the system. It will take many months, if not year and a half, to get to know the system. So it's important that leadership has a thorough understanding of the system. And again, there should be a certain understanding that they're going to learn as we learn as well, you know? Improving patient outcomes. With the EMR system, no medication can be validated unless it is ordered by the physician and unless it scans to that patient. So it will also be important to have functioning armbands, you know. This will ensure correct client receives the correct medication. Oftentimes 2 timers are implemented. So if you give a medication fragment, you give it too late, it may not allow you to give it. Or it may ask you to give an explanation why, and people will read that you gave it late, you know, and they're going to know. It's going to show up in the report. This is going to drastically reduce medication errors and in time save lives and save finances for the hospital. Also, it will raise customer satisfaction. We'll get higher scores. You know, scores are important. The surveys will come back more positively as well. How will we know it's working? Well, one way that we can evaluate the effectiveness is, anytime we have a medication error, we do an incident report. So we can compare the incident reports pre-EMR to the incident reports post-EMR. That will be a pretty good indication of how well the system worked or is working. Employee satisfaction is another great way. How is the system flowing for the nurse, for the physician, for the pharmacy? Is it better than the old system? What areas do we need to tweak, you know? This should make it run more smoothly. Timeline of evaluation. There will be various levels of evaluation. First of all, maybe about a month. We'll check in and see how everyone's doing. This is also going to be a time of continual education. There may be someone on the floor with us constantly going over the system. If we have any questions, again, that could be the charge nurse or could be another person appointed by a team. The second would be around 3 months. This is going to be aimed at staff support and seeing what staff needs, what glitches they're finding in the system, what can we do to improve the system, who needs more help, you know, or any nurses lagging, you know. And then again at 6 months, this interval we will aim at the actual system. You know, okay, how is the system flowing? Again, what glitches have we found? How can we streamline it? Do we need to add anything such as alerts, faster data, you know, faster speeds? Evaluation shouldn't stop there. It will continue in 3 to 6 months intervals, for you know, constantly upgrading the system. You know, building on the system, things of that nature. We're just about there, friends. Thank you. What can we expect? Decreased medication errors, save lives, increased hospital income, increased workflow efficiency, increased patient outcomes and patient satisfactions, and increased hospital scores and better Joint Commission visits. We all know we get a little scared when Jaco comes, you know, so Joint Commission. So, but is there any bad that comes with the good? Yes, often we have resistant staff. You know, we have a little rebellion. We don't like change. Our way is the right way. We don't want to do anything different. Again, like I stated earlier, we can expect that we'll probably lose some people as a result. And stressful situations. At first, we may have longer med passes because we have a new system. You know, we're not familiar with it. It takes longer to scan a patient armband. Well, you know what I mean. There's sure to be challenges that come with any new change, especially a major change. This is very common, but again, it brings upon growth in the system, and overall, it makes the institution, the hospital, a better place, makes staff more efficient. It really cuts back on human error. In conclusion, and I'm going to read this verbatim just because it's my conclusion and it's important. In conclusion, EMRs save lives and save money. They are a systematic way in which hospitals can safely and effectively deliver medication and streamline workflow. I believe that while a change in medication administration systems may deliver some challenges, it will be worth it will be well worth it. It will take a strong team of leaders and a group of employees that are eager to learn new material to better serve the patient as well as the hospital in the long run. So I really want to thank everybody for their time, and I would like for people to ask questions if you can.
Were you here for the implementation of our system on Sorian?
Yes.
Yes. Do you feel like we went along about with the plan of 1 month, 3 months, 6
Yes.
months?
Yes.
That we did a good job
I
evaluating?
think we did, yeah. I think we did a good job, and I think that we continue to do that. And like I said, in Nurse City yesterday, Tammy King was talking about, how can we get the quicker, how can we make the system faster? It is just the new system, 9 months old, what can we do to make it more efficient, And, yeah, I think that we have definitely done that. I think that I do think we could use like a Sorian too, though.
I was gonna
I
ask
think
if
we
if
need
you
a-
think we're up for
Yeah,
it's about time for
Yeah,
some more updating.
for instance, like when we go into like looking up ultrasounds, looking up physician notes, a lot of people still don't know how to do that. And it wasn't taught, I don't remember it being taught in Sorian, and maybe it was, but we were so focused on the
It
function
was-
of putting in
it was
assessments,
not. It was not.
That stuff needs to be gone back over, because it's important that I find that it's mainly people who have time to just go
Play
through
with
the
it.
system that actually know that stuff, And I've learned it just because people have shown me, but I think that it would be important to have a Sorian too.
I think they were talking about it at Senate, having, a phase 2.
I think there's some upgrades.
Yeah.
I think some upgrades are gonna be.
She said they're gonna make the system faster, We'll see, right?
Yeah. Well, thank you, Joe.
It was great, though.
You did a
Good.
wonderful job.
I just wanted to ask you, since you were here before, do you think your med time passing has decreased about how much percentage or has increased by how much?
I'm not sure I think it's the exact same. It's 2 hours. And
For your 6 patients?
yeah,
5 to 6
but
patients?
for 6 patients, it's 2. For 5, about an hour and a half. But I'll tell you this, I used to, after every 9 p.m. med pass, I'd go back and double check. I feel very safe and secure now knowing that if I did not, that this patient every patient got the med they were supposed to
It was
get.
paper before. I wasn't here during the change.
Yeah, they just switched about 9 months ago.
We had that at my old hospital and I worked nights and it was kind of scary. Like you said, your thing to be checking at 3 a.m.
Yeah,
That was kind of scary.
and the cab is still paper,
Wow.
so that's kind of, it's
Well, they're
kind
using
of.
Sunrise.
Well, we use Sunrise system, but not a,
Not for your meds?
yes,
but for-
not for
Wow.
meds. Yep.
Um,
So that can be a little bit, you don't
DeKalb
scan
Hospital?
it. Yeah, DeKalb Hospital.
I thought everybody
It's in
had
the, you
EMR.
click it in the computer, but you don't scan the patient.
Oh.
So you take the
Oh.
meds, so you go through and you click the meds in the computer, but there's
Yeah.
no scan system.
Oh.
It doesn't have to be scanned though.
But that's a lot what I, no, it's not, but that's what I'm saying, it should be
It should
mandatory
be.
to scan, because what's the point in,
I
you know what I
agree.
mean, like,
I agree.
You can
Because
still.
you can work around that. People who wanna do bad can work around anything. That doesn't guarantee
Absolutely.
anything.
True.
Yeah.
Because there's still errors being made with the scan. Because people at Piedmont are putting in wrong blood pressures, wrong INRs, wrong what. I know for facts.
I'm listening.
they put it in the
So
wrong in without
things are
checking.
not what,
They
Yeah.
say. See,
So they
things are
have-
not what they seem. Yeah.
right, it's not the
Bad
perfect,
practice is
it's
bad
not the
practice.
perfect,
It's
perfect
not the
system.
Yeah.
Right, people can find ways to make mistakes.
Mm.
Well, I don't see this here as much, but like, at another place,
It's the ethics of the person.
Mhm.
Yes, it is.
it is.
A big part of that
That's
is
true.
absolutely.
You know what I mean? If
Yeah.
you're gonna check and balance yourself and be, then you're gonna have a good outcome. You know what I mean?
Yes.
Because even with this system, like the patient went to surgery, somebody forget to put the fragment off, the patient gets the fragment. The patient was supposed to get the fragment in the system,
Yeah,
but was the patient supposed to get the fragment?
No.
yeah, no, they weren't.
Right,
It was supposed
so
to be
the
DC.
I
EMR
got
worked,
you.
Yeah,
but it's wrong.
yeah.
That's right.
Where was it wrong?
Well,
The
that's my
pharmacy, the
issue
doctor,
is-
or the nurse, it was still wrong.
Right.
So that was an error.
Yeah.
So there are still problems in this system.
Yeah.
Yeah,
You know what I mean?
Yeah.
Yes,
So
I
it's
do.
not a perfect system.
Well, some
No.
of the bigger picture thinking, the electronic bar doesn't, it narrows your focus to make sure right med, right patient, or, you know,
Well, they get so many steps.
yeah. And then also like, you know, when you, like, just say, take a simple bowel protocol, the protocol sheets in the charts. You know, you can over a period of 5 days, just quickly look at what was entered and, you know, you can see a whole chain of thinking in pharmacy, who's intervened in the thought process on medications, interventions, things like that, that would go into the chart. Sorian doesn't allow you to see that thinking. You know, you have to click over here and you have to click over there. You know, it was like this, when you opened up that red chart, you could see like, you know, 10 things post-op that were changed, and you're like, you know what? I need to check that
You can go through a
fragment.
trail, you can
Right,
trail.
yeah,
Yeah.
yeah.
You can't.
You can't trail
You
so
the
well.
trail, you gotta work hard.
It's
Yeah.
hard.
The trail, and it can be hidden, the trail can be hidden. But you, paper chart, you can find the trail
Because that
faster.
takes
Yeah.
2 pages and you could go, I better check that fragment order, you know?
Okay, my camera's running out.
thank
I
you.
really, I really am grateful to you all for
Thanks,
listening, and thank you so much. Thank you, thank you, thank you, thank you. God bless
You
you
did a
all.
great job. And
Thank